76-year-old lady, morbidly obese, side swipe deformity, right side valgus, left side varus. Because of the comorbidities and the body habitus, we decided to do it in a staggered fashion. We did the left side first. So this is the scanogram. You can see it's a 29-degree valgus deformity and her mobility is grossly restricted. So in such cases, she was both valgus as well as hyperextension. Here, the decision-making points that we had to consider is what are the bone cuts, what alignment we would leave these patients at the end of surgery, what is the rotation on the femur, and is there requirement for releases. So if you can see the data that we got from the software, the joint was very lax. So the issue was not correctability. The joint opened up both in flexion extension. The issue was the hyperextension. So here you can see that the gaps were too much, 28, 29 in extension, 24 and 26 in flexion. So in such situations, when you have so much gap, your options are to actually distalize and proximalize, distalize the femur and proximalize the tibia. So how much would you go up to? Because I had to really come down in terms of those skim cuts. So in this particular patient, I removed just 1 millimeter on the lateral side, on the distal femur, 3 on the medial side. Posterior femur was 4.5, 5.5. Distal tibial cut, though this is getting measured from the defect, it was almost 0 on the lateral, 0.5 on the medial. In spite of doing all this, the tibia was kept at 90, and the femur was around 1.5 degrees of valgus. Because of the distalization and proximalization, there was some amount of lateral tightness that came in extension at the end of the trialing, so I had to do some ITB release. And in spite of...
Let me stop there. So, well, how did you release? Did you completely release the IT band, or did you pie crust it? What did you do?
So I usually use 11-number blade, and then either you go inline or horizontal or perpendicular based on how much release you need. Since this is a robotic system, each amount of release you can actually quantify and see how much the lateral side is opening. In spite of distalizing the femur by 5 millimeters almost, and tibia was also raised almost by 4 to 5 millimeters, I still ended up with a 13 millimeter poly. There was a firm endpoint at the end of the procedure.
So let's go back to the one slide back. There was a large posterior osteophyte. Yeah, there you can see it on the CT image there. Yes. So how does that factor in? We talked about it earlier. How does that factor in into your balancing?
So if it's a flexion deformity, it is a big, it's a bit of a concern for me. I would undercorrect my deformity because my extension gap will open up after removal of the osteophyte. Since this was already such a...
You're guessing that, or is the robot telling you that?
Sorry?
You're making that assessment, but you're guessing how much more it's going to open up when you, right?
It has to be an estimate because there is no recommendation looking at the volume and the size of the osteophyte and how much correction you actually get at the end of removal of the osteophyte.
Right, so I mean, I think that was the point made, though, in the prior panel, that this is one of the limitations of robotic surgery, is that we don't know how to quantify those, those changes that are made to the soft tissues once these osteophytes are removed, or if you do a tibial reduction osteotomy. So all these things are very hard to quantify robotically.
Especially to...
in terms of the posterior osteophyte, it's very important to remove that early in the procedure and then do your measurements. So we always, for many years, we've been excising with the curved osteotome right in the beginning as part of the exposure.
So we've also...
When you do your measurements, you've already taken that out of the equation.
Yeah. Especially for varus knees, we do that. We take a skim cut on the posteromedial aspect so that I can gain access to those posterior osteophytes, and only after that we do the balancing.
Okay, go ahead, Monty. Your question?
In SUHAS, there is a, if you see the preoperative X-ray, in the sagittal plane, there is a lot of posterior tibial slope.
Yes.
But your, post-op X-ray shows there is an anterior slope.
Yeah, I mean, it looks like she had a stress fracture.
So she has almost a 19 degrees posterior slope on the lateral side and almost 20 degrees posterior slope on the medial side to begin with. So I think this was probably not native, but because of the progression of the deformity, that was the amount of slope or remodeling that had happened in this patient.
Intraoperatively, how much slope you take in this?
If I remember correctly, it was 3 degrees.
And is that a fixed number that you have, or is that something you calculated?
So for a PS knee, the recommendation for a triathlon is 3 degrees of slope.
So that's what you're just,
But if I do a CR, I do give a little more slope, trying to match the native.
you wouldn't put 20 degrees of slope in there, would you?
So the maximum we've gone up till is 7 degrees.
Do you think the hyperextensions which you have with a significant posterior capsular laxity, the slope, if you give less slope, it is better actually for you? It's nothing to do with the PS or CR need. The amount of laxity which you have, you give less slope, you're automatically trying to correct some amount of posterior tightness.
So
laxity
I let the
of the
balance
tissue.
decide that for me in terms of implant positioning. Here, my gaps were almost 24 and 26 in flexion. So already the effort was to actually decrease the gap.
If you see the postoperative X-ray, can you show the post-op X-ray?
SUHAS, can I ask a question?
It looks there is a anterior slope in the tibia, isn't it? The
Yes.
the stem extender which has been shifted posteriorly, that is because of the posterior slope. Anterior slope.
Would upsizing your femur have taken care of some of the flexion and stability?
When you do gap balancing and you move the implant around, you're talking in terms of absolute numbers in gaps. So there is no role for upsizing or downsizing the femur.
But by doing that, you would actually reduce the flexion gap. And one of the things that you want to do, because out here you have a hyperextension deformity, that would be one of the components that you might, not ideal, but this case is not ideal.
Yes.
And this is really a compromise situation. Everything that we're talking about is some sort of a balance between what should be done and what is actually feasible to be done. Because you're converting from 22 odd degrees
Almost
to
28
yeah,
millimeters.
28, whatever, to 3 degrees or 5 degrees. So just a suggestion, maybe upsizing that femur could have made this a little bit easier.
I think what you've done actually is perfect because he's not upsized the femur, so you have a larger flexion gap, and he's slightly anteriorly tilted the tibia, so he's got a larger extension gap, so he's matched the two. So I think he's balanced it out very well.
As the gaps came down, if I needed little more tightening of the flexion gap, I would have just moved the femur posterior instead of upsizing it. But if there is notching, then I would definitely upsize the femur.
Could you show us the outcome of the patient? Do you have any follow-up or something?
Not yet. This is quite recent, so and we have to do the left side also.
Tibial component looks little bit in varus as well.
So overall was 0.5 degree of valgus, what we measured at the end of surgery.
Wait, you do have clinical follow-up?
So 3 weeks post-op, this patient had a buckling, and then she ended up having a fracture on the distal aspect of the femur. So here the question for me was it an insufficiency fracture? There was no height trauma in this patient, or is it just purely because of buckling, or was it because of a pin tract fracture? But here the pins were slightly more proximal. If you can see posteriorly, right after post-op, you can see there are none of these holes were there. So she just had a buckling and then she ended up with this fracture. So my question was the role for prophylactic intramedullary rod on the femur. Is there current recommendation? We have for the tibia, but it's mainly for obesity and loosening. But on the femoral side, I couldn't find much in terms of recommendations. Purely is it based on our ability to assess the bone quality? Because this was a PS femur and this was triathlon, I couldn't add an extension on the femoral stem. I had to do actually change to a revision stem in order to put a femur extension.
It's, you make an excellent point there that most of the modern primary knee systems now, you don't have the ability to put on femoral stems. I think we almost went backwards. And almost every company is the same in that regard. So I think, it's one of the reasons why I kept using an older design because I do use residents and fellows, and things do happen occasionally, and you do need to put a femoral stem in occasionally, in cases of notching or otherwise. So, yeah, that's a big problem. But
This is the only article I found from Peter Skulko where this was the exact combination that I had, 75-year-old lady, obese, osteoporosis. And when you have a severe preoperative valgus, and when you correct them to neutral, you tend to overload the medial side and cause an insufficiency fracture. So in such patients, either you do a CR knee, or if you do a PS, then do it with an implant which has a femoral extension for a primary femur.
But how sure it wasn't your pin tracks?
So they were more proximal, so that is the reason I put all the 4 etiologies. Because it was a bicondylar fracture, if it was more pin-tracked, it should have been more proximal and mainly involving the medial condyle. Insufficiency fracture is the only one where 50% of the times in a valgus knee it is either medial or it could be both medial as well as lateral, as it was in this case.
What was the size of the femur in this case? Was it
2
a small-
femur, 1 tibia.
Yeah. So this has actually been described by Sami Tarabici in Journal of Arthroplasty 2017, particularly with small size femurs,
Yes.
PS designs, and is a very similar case to what you are demonstrating.
There is a ratio between the prosthesis versus the distal femur, the breadth.
Yeah.
So when the ratio is smaller, the chances of fractures are higher.
Yeah, because once you've taken the box out, there's not a lot of bone
It's
on
the
the
box
medial
cut,
lateral.
yeah.
So there was osteoporosis, the box was big, she buckled, so there were multiple factors causing this fracture.
All right, so now you got a challenge. Now what are you going to do?
So we went back in, it was a Rohraback type 2, the implant was stable, so we had to fix it with lock plates on both sides.
Who was, everyone agree with that treatment plan, or how old was the patient?
She's 76.
76. Does anybody have any desire to consider doing a DFR, a distal femoral replacement? Everybody would fix this? Okay. I will say, though, that more and more patients are getting DFRs, especially when they're approaching 80, because it does allow them to immediately weight bear. Did you make her partial weight bearing?
So there is a different kind of scenario where you already have arthritis and patients have a distal femur fracture. Those are the ones where, and they are above 75, 80 with this kind of comorbidities. We try to do a single procedure like a distal femur replacement.
Yes, but I'm saying even in the setting of supracondylar fractures, we're doing it, more often.
Yeah, so that at least we can get them
what,
out of...
What kind of weight bearing did you do for this person?
For this, right now, she's non-weight bearing. At least we will wait for 3 weeks and then probably slowly start
Because
using a
I
brace.
saw her struggle in the initial
Yes.
video that you showed. Yeah, so this is going to be tough for this lady, right? And
She just waited too long to, get the surgery. So she was so far down in terms of her general ability to ambulate.
Would there be a role to give, injections of teriparatide or, zoledronic acid or any of these pre-operatively before you take them up? Because you can see very distinctly there's severe osteoporosis.
Usually they automatically go on these regimen right after surgery, right from anti-resorptives to parathyroid hormone.
Giving them pre-op will not have much use because patient won't be able to walk, and unless you load the bone is not going to get better. So the best idea is to get them corrected, make them start weight bearing, and then start all these chemical therapy so that the
So
bone becomes better.
we've had many cases where patients actually walked and never had such an issue. But probably physiologically she was so weak that she ended up here.
well, I already know what I'm going to do next year. I'm going to invite a bone metabolic specialist, and we're going to get some lectures. Because, clearly from today and from years past, the osteoporosis and osteomalacia, the vitamin D, this is a serious, problem in this subcontinent. And, I think either medical doctors or, it just needs to be more recognized and treated. It's a major problem in this country. You have a question, microphone 2?
So Haas, do you use that long leg brace when she started walking? Walker with long leg brace. Have you used that post-operatively?
So we usually use, and we...
This case?
Yes, this case. We usually use a range of motion knee brace. so that we allow them 90 degrees of flexion. But it's definitely...
On walking, she was using that long leg brace or not? This is the
So
question.
the history is usually quite
So
suspect.
my suggestion, what we do, when there is a severe osteoporosis, overweight patient, walker with long leg brace,
So
that,
yeah.
that minimize the chances of
Chances.
fracture.
Maybe she was not
CR
compatible
knees.
with it. She had a brace to begin with.
Okay. All right.
Thank you.
Thank you very much.